Welcome back, everyone, to Bone Density Education. We have a special guest today to talk about men's osteoporosis because osteoporosis is often seen as a women's disease, but the reality is that almost 40% of osteoporotic fractures worldwide happen in men. And to help us unpack why this matters and what men can do about it, I'm joined by Professor Peter Ebeling, one of the world's leading experts in bone health. Just to give you a little bit of background, Prof. Ebeling was the past president of the American Society for Bone and Mineral Research, the first non-North American to hold that role. He's a board member of the International Osteoporosis Foundation, and as an endocrinologist and a researcher, he has over 550 peer-reviewed publications. And on top of that, Professor Ebeling wrote the paper on osteoporosis in men, published in the New England Journal of Medicine, and co-authored the Asia-Pacific Consensus for the Management of Osteoporosis in Men. So I'm very excited about this session. And Prof. Ebeling, thanks for being here.
Thanks a lot, Tom, for inviting me. And that was a very kind introduction.
So you're very welcome. I think we're going to learn a lot here today. So let's jump in. So when it comes to men's osteoporosis, it often flies under the radar. But for the men listening, what are the key takeaways they should know straight away?
I think osteoporosis in men isn't that uncommon. And as you said, over a third of fractures due to osteoporosis actually occur in men. And about 1 in 5 men will have a fracture due to osteoporosis in their lifetime. Now, when the risk of these fragility fractures starts to increase is about the age of 60 or above, when men tend to get broken bones. And they tend to get broken spinal bones and other bones in the body, such as the upper arm and pelvis. But what we really want to avoid is the hip fractures that occur later in life. And when it comes to those broken hips, men are a weaker sex than women in that they die at a higher rate after a hip fracture than do women. So the risk of dying after a hip fracture in men is around about 30% in 12 months. And that's higher than in women. But really what most people fear after a hip fracture is not being able to return home. So that's, if you like, the end point of the journey, and we want to stop that happening. And there are many positive things we can do as we get older to stop that happening.
And so how is osteoporosis in men different to that in women?
Yeah, it's not too different if we think about the effects on the bone structure. Now, our bones are living. They're not something you see in a horror movie as a skeleton. Our skeleton is remodeling all the time. And so our skeleton today is completely different to what it would have been 10 years ago. So the whole skeleton remodels over about 10 years. Wow. And the remodeling cycle at individual sites takes a few months. So if I was silly enough to go jogging in the morning, I might get some micro damage in the bones in my feet, and the body would detect that the bone was damaged. And then the crew comes in to resorb the damaged bone and build new healthy bone. And that whole process takes about 3 months, but it occurs all over the skeleton over time. So we're refreshing skeletons all the time.
That's actually really inspiring for me personally, and I think for a lot of people, because what I heard a lot when I was first diagnosed is that we don't lay down new bone after 30, was this kind of catchphrase that I heard a lot. But then what you're saying there is that we do in fact lay down, and we regenerate our entire skeleton in 10 years.
Correct, that's right. And what they probably meant by that is you've achieved peak bone mass. So your optimal bone density, which is determined by your genetics, but also the environment and how much exercise you do before puberty, around the time of puberty, all of these things can influence what we call the peak bone mass, which is around about the age of 25 to 30. And then after that, the bone mass gradually does decline, but at the individual sites, there's still ongoing bone formation. And we can target that bone formation through exercise, what we call osteogenic exercise, to stimulate bone formation. And now we've got drugs that can actually work to treat osteoporosis by stimulating bone formation. So I don't think you should be pessimistic about it. that there is ongoing bone formation as we get older.
Yeah, excellent. Yeah, that is inspiring for me, knowing that there is the bone is actively regenerating itself and evolving over time, and we can kind of direct it into which way we want it to go. And you mentioned something earlier that men suffer more from their fractures than women. They pass away at a higher rate as a result of osteoporotic hip fractures. Why do you think that's the case?
Well, when you look at the causes of dying after a hip fracture, really what are increased are cardiovascular events and infections. And we're not quite sure, but we think probably the men that get a hip fracture are perhaps a bit frailer and have more comorbidities or other illnesses compared with women. So
Okay.
that could account for some of that increased risk of dying and disability after a hip fracture in men. But it's certainly something we are, like to prevent by creating the opportunity for increasing exercise and good nutrition, avoiding too much alcohol and stopping smoking. All of these things can prevent that progression and
Yeah.
improve your bone health as you get older.
Yeah, okay, wonderful. And so for men, what role does testosterone play in men's osteoporosis? Because we often hear about estrogen in women. What about testosterone in men?
Yeah, testosterone is important in men, but interestingly, estrogen is more important for the male skeleton as well. And you might say, well, how do men get estrogen? You know, their main hormone is testosterone. So the testosterone is produced by the Leydig cells in the testicles. But interestingly, when it comes into, say, fat tissue or other tissues, it gets converted by an enzyme into estrogen. So it can act locally on the bone cells through conversion to estrogen or through a testosterone metabolite. So there have been studies that have been done looking at the relative importance of estrogen and testosterone in men, and some of these were done by researchers at the Mayo Clinic where I used to work. And they've shown that estrogen is relatively more important in men. So it's through that conversion locally of testosterone to estrogen. But you need the testosterone to achieve that conversion. So that's
Okay.
why testosterone is important. Sometimes as men get older, the testosterone levels can gradually decline. But we really have strict criteria for diagnosing testosterone deficiency in men. And in fact, what we recommend is not testosterone treatment for men with osteoporosis, but anti-osteoporosis drugs. In fact, there was a recent study of giving testosterone to men with low testosterone levels, and their risk of having fractures was actually increased for some reason.
I read that
Now,
study. Yeah, that was a surprise.
now that's crazy stuff. We weren't anticipating that, and we're trying to work out why that would be the case. And it may be that the men, their muscle function was improved, they became more active, and because they were more physically active, they may have got those fractures. So it was a
Yeah,
bit of
I was kind of thinking about that too. Like if they're increasing their testosterone, they're more energetic, they're more they're more motivated. They're probably doing a lot more, and they're maybe a little bit more aggressive with their enthusiasm and maybe tripping over or hurting themselves as a result. But so what about things like hypogonadism? We've seen a lot of studies about that and how it may contribute to osteoporosis in men. Can you talk us through what that is and how it plays
yeah.
a
So
role, or if it doesn't?
hypogonadism can definitely contribute to osteoporosis in men, and where we can see it really is in young people who have maybe a cause for a low testosterone level from birth, and then they don't achieve their peak bone mass. Even having delayed puberty as a normal person without a genetic cause for a low testosterone, that can also impair your peak bone mass. So that's one way where the
Mhm.
low testosterone can affect or increase your risk of getting osteoporosis. And then if it occurs later in life, as we said, the conversion of estrogen is reduced. There's a low estrogen level as well as testosterone
Uh,
level. And then that will increase the breakdown of bone through increased activity of the cells that break down bone called osteoclasts. So there can be this imbalance between bone formation and bone breakdown, favoring bone breakdown. And that's why this imbalance in sex hormones can result in osteoporosis. So the question is, what do we do to treat the hypogonadism? Well, we have to treat with testosterone because there are other benefits of testosterone apart from on bone. It's on libido and sexual function and muscle as well as bone. So it's important that these men have their testosterone replaced. But the thinking is if they have low bone density, they probably need an osteoporosis drug as well as the testosterone replacement to prevent their
And so
risk.
then how closely should we be tracking testosterone and estrogen in men who have osteoporosis?
Yeah, so usually what we do in a man who comes in with osteoporosis, we do blood tests to look for underlying causes of osteoporosis. And we could look for celiac disease, wheat allergy. We could look for bone marrow problems. And one of the other things we look for is a low testosterone level. So if we do find a low testosterone level, we usually treat it. And it just really depends on how low the bone density is, whether we give an anti-osteoporosis drug as well.
And interesting, because a couple of things there. So I myself I don't have below normal. I have just on the edge, And I've spoken to a lot of men who are in that similar position where they're not quite below, but they're low and they've got osteoporosis. How should that be something to look at or not? Do you think
We
that
wouldn't
plays a
recommend
contributing
testosterone
factor?
replacement in that situation. And sometimes there are things that you can do to boost your own testosterone level. And one of the most important things is getting enough sleep. That will help boost the testosterone level, and exercise can also have an additional benefit on that. So they're just some little things to do to try and help your testosterone levels increase endogenously without having exogenous testosterone. But we usually don't recommend testosterone treatment in those borderline cases. We only treat with true deficiency. And again, we have to think about other ways of improving the bone density in men with borderline testosterone levels and osteoporosis.
Okay, so it sounds like that's not the main factor that you would be looking at and focusing on in those men. It'd be more so let's look at any kind of other treatments, and after that look at potentially boosting testosterone.
Yeah, that's correct.
Okay, and so what are some of the other or most commonly overlooked risk factors for men beyond low testosterone levels when it comes to osteoporosis?
Well, I think if we think about globally, probably the most common causes would be smoking and alcohol excess. They can both have adverse effects on bone.
Yeah.
And of course, there are other causes, such as medications. So, corticosteroids or steroids are used pretty commonly for treating inflammatory diseases and other conditions, and they can have an adverse effect on your bones. And then treatments for prostate cancer. So when men have prostate cancer and then go on a treatment to lower testosterone levels, we call that androgen deprivation therapy. That can also result in an increased risk of fractures and low bone density because of the low testosterone levels. So these are some common causes. And then, as I mentioned, wheat allergy, celiac disease, or having a low vitamin D level if you don't get out in the sun much, or a low calcium intake can also contribute. And there are other rarer conditions that can also cause osteoporosis in men.
Okay, so it sounds like there's quite a few things to investigate and look
Yeah,
for.
we pretty carefully investigate men with osteoporosis because it is less common than in women. And also, if a man is younger, we probably throw more investigations at the person. Another cause in younger men can be HIV, and treatments for HIV can also, some of the treatments for HIV can also reduce bone density. So these are some of the patients that I would see in my practice.
Yeah, wonderful. Yeah, I remember having a whole range of tests being done by my endocrinologist when I was first diagnosed, and it really came up with no specific cause, and we have the idiopathic
Mm.
situation, and a lot of men I've spoken to are in that category, and
Yeah.
they feel quite frustrated. Like, what does this mean for me? What do I do? Where do I go to from here?
Yeah.
What would you say to them?
I would say don't be worried if we can't identify a cause. There could be an underlying genetic cause. So we know that if you have a family history of a hip fracture in your mother or father, that's an indication of a genetic cause, and you probably have an increased risk of having osteoporosis. But we're not at the stage where we can order a panel of genetic tests and say, well, this is the gene that's in your family that causes the osteoporosis. We think there are many genes that are involved, not probably just one. So I think genetics can be one of the causes of idiopathic osteoporosis in men. And I think this group is a large group. And what we know is that they respond well to treatment. So it doesn't matter if we can't find a cause, you'll still respond very well to treatment, like if we had identified a cause.
Okay.
But the useful thing about identifying a cause is we can treat the underlying cause first and see how the bone density improves. And there can be many hormonal conditions like an overactive thyroid or an overactive parathyroid gland that can, or a low testosterone level, as we mentioned before, that we can try and treat and see what effect that has on the bone density before we then launch into other medications to boost the bone density.
Yeah, and so from what you're saying, it really is very aligned with the fact that men often get secondary osteoporosis as
Yeah.
opposed to women who have primary. Can you talk us through the distinction between those two and what they mean for men?
Yeah, so secondary osteoporosis just means we've been able to identify a pathological cause for the osteoporosis. Some of the ones I've mentioned already. We wrote a big paper on secondary osteoporosis in endocrine reviews during COVID, and what we focused on was men with osteoporosis because we tend to investigate men for those secondary causes. So we say primary osteoporosis, it's a bit like idiopathic osteoporosis when we haven't been able to identify a cause. Now, women get osteoporosis more than men because they go through menopause where there's a fairly rapid decline in their estrogen levels. And there is a rapid rate of bone loss in women for about 3 to 5 years around the time of menopause. It actually begins before the menopause in perimenopause. Of course, men don't go through menopause, so they don't get that additional rapid phase of bone loss. But then after that phase of menopause in women, there is a gradual rate of bone loss, and that occurs in men as well. Now, we think that gradual rate of bone loss is probably related to imbalances in sex hormones and relatively low sex hormones as you get older. And that's why there could be this age-related bone loss occurring. And that's why it's important to focus on things that might modify that rate of bone loss. And that's making sure that you've got a calcium intake of about 1,000 milligrams a day, which means about 3 serves of calcium-containing foods. So it doesn't have to be dairy products. All of the plant-based milks have calcium added, like soy milk or oat milk or almond milk. And then a small tub of yogurt would be another serve, a couple of slices of hard cheese, and the harder the cheese, the more calcium in it. So Parmesan cheese probably has the most calcium, or a
So that
handful of...
we can add extra parmesan to the
Yeah,
pasta,
that's
and
right.
extra bolognese for the protein.
Exactly. And a handful of nuts would be another serve of calcium. And then, of course, depending where you live in Australia, you can become vitamin D deficient during the winter months, particularly, and that's fairly common in southern Australia. So if you're living in southern Australia, we'd recommend taking a vitamin D supplement over the winter months and getting a little bit of sunlight during the other times of the year to make sure you've got an adequate vitamin D level. And the third component is adequate weight-bearing exercise. So the best type of exercise is high intensity progressive resistance training. It's not just walking. Walking doesn't do much for your bones, and neither does swimming or cycling. So I think it's really important to do that progressive resistance training with weights.
So what does that actually mean and look like?
Yeah, so what it looks like is going to a gym and lifting weights and progressively increasing the weights that you lift and concentrating on upper body and lower body exercises. There are some programs that are specifically designed to increase bone density. We did an exercise study called Osteo-cise in the western suburbs of Melbourne, which was a group exercise program. But there is one that's running around Australia now called the Onero program, Onero, and that's based on a trial that was successful at improving bone density called the LIFTMOR trial by Belinda Beck in Queensland. And a lot of gyms offer the Onero program, which is what I just described. It's actually with free weights and progressively increasing those weights. I'm not sure if you're doing the Onero program, Tom.
No, I'm actually doing something along the same lines. I really got into powerlifting after
Yes.
I was diagnosed after I had a broken wrist, and that was the third fracture in 18 months. And so I had exercise physiology rehabilitation for that wrist, and that kind of led to the next thing. I asked for more exercises. We figured out that I hadn't rehabbed my ankles from a previous fracture in both, and so I kind of slowly got better and better and stronger, and I wanted to keep challenging myself. And I read the LIFTMOR trial, and we had Prof Beck on here about a year ago, which was great. And I got really excited by powerlifting. It allowed me to go to challenge myself and push myself, and so I'm kind of very much into that. But I know that once I've reached the limit there, I'm going to transition into Onero to kind of more maintain and kind of
Yeah, that's
I
right.
know it's a slightly different program than powerlifting, but
Yeah.
it's very exciting. And I've been talking to a lot of men about this, and we often encourage weightlifting and that kind of thing, but they don't often like it. They don't like to be in the gym. They just don't like that kind of thing. Are there any other forms of exercise that would be useful?
Well, I think you could do a home-based exercise program, get some free weights and do it in your own home if you don't want to go to the gym. So on the Healthy Bones Australia website, we've got a list of exercises that you can do at home to try and boost bone density. But some of the exercises like skipping or hopping or jogging can also be good because they provide the sort of impact that the bones need. So those are other useful exercises. And we ought not to forget about balance training exercises as well, because we don't want people to fall over. So none
Yeah,
of my
no.
patients are allowed to fall over
Yeah. And what
because
about things like pickleball
that's
or
their
tennis
practice.
or those types of activities that people just like to do socially that might also be helpful?
Yeah, so we know that Tai Chi has been shown in randomized control trials to prevent falls, and balance exercises are very useful to combine with
Mhm.
those progressive resistance training, particularly in older men. Yeah.
Okay, wonderful. And then when it comes to prescribed medications and treatments, um, one of the frustrations that a lot of the men have that I speak to is they feel like a lot of the research on particularly around the treatments, that men feel like they're treated like big hairy women, essentially. Do you think that that's a fair criticism in terms of the current treatment approach, or not? What are your
Um,
thoughts on that?
yeah, probably not, because I think there have, when I started doing research in this area, there weren't any treatments. Now we've got about 8 treatments that are all
Mhm.
very effective. So I think we should be positive about the possibility of improving bone density and reducing fractures.
Yeah.
And the studies in men have really been mainly bridging studies. So we've got the anti-fracture data from the studies in women,
Hmm.
and then there are smaller studies looking at changes in bone density over 12 months or 2 years in men. There's been one study using intravenous infusions of zoledronic acid, which actually looked at spinal fractures as a primary endpoint. So there has been one study in men looking at fractures, and another study with denosumab in men on androgen deprivation therapy, which also looked at spinal fractures. So both of those studies showed a reduction in spinal fractures with either zoledronic acid or denosumab in different populations. But then the other studies with the other medications we use, say alendronate, that improved bone density in men. And there's been a study with denosumab and also studies with the anabolic drugs, teriparatide and romosozumab in men, and they all were equally effective with very similar improvements in bone density as seen in postmenopausal women. So I think we're in a great situation now where we've got a lot of effective treatments that are available for men with osteoporosis. So one of the ones I find is popular with men is the intravenous zoledronic acid, because a lot of men don't like taking tablets. And we know that this medication has a long half-life, and you may only need an infusion every couple of years. So it's a minimal inconvenience
Wonderful.
and has a long-lasting effect. So often we might use 3 infusions and just see how things go after that. So
Okay.
I think there are lots of good treatments that we have available.
Excellent. Well, that's reassuring. That kind of clears the air in a way, because a lot of men feel frustrated or left out, but that's probably because of a lack of understanding of what's out there and what is available more than anything else. And the next kind of thought in my mind when it comes to the medications is the adherence and the compliance rate. The studies are showing that up to 50% of patients stop their medications within 12 months. Why do you think this is happening, and what could be done to change this?
Yeah, I think it's probably having a chronic disease where you may not realize what the benefits are, because you know what the benefit is. You don't break a bone, but that's a hard thing to determine. But you can get positive feedback by seeing your bone density go up or your bone markers, the rate of bone breakdown reducing if you're on some of these anti-resorptive drugs. So there are benefits you can see quite quickly. With the bone turnover markers, those changes occur within about 3 months. With the bone density, it takes about 1 or 2 years. But I think the challenges have been with the weekly tablets. There are monthly tablets available as well, but some men are not good at taking tablets and they just stop taking them, I guess. And sometimes there are associated side effects like a bit of reflux or tummy pain, and that may also stop people taking them. So they could be related to side effects or just not continuing with the treatment when they should. But I think, that's something we need to address to make sure that men understand that osteoporosis doesn't go away, and it really means it's lifetime management of their osteoporosis. And the treatments may change over their lifetime depending on how they're going.
I like to say that osteoporosis is like this lifelong game of keepy uppy, where you play with the kids with the balloon, hitting the balloon up off the ground. Your bone density seems to kind of keep wanting to drop. But we have to keep doing things to keep bumping up that bone density for the rest of our lives.
That's right.
So you mentioned something interesting about bone turnover markers. DEXA scans we can only in Australia get every 2 years.
Yes.
But that's a long period to wait and hope and pray, and maybe it'll work, maybe it won't. What's happening with my bones? But bone turnover markers are a potential thing that we can do between the DEXA scans. Can you tell us a bit more about the usefulness of them for that reason, how they can be used, what GPs can do to help their patients stay motivated?
Yeah, so these bone turnover markers are little chemical measurements that are either bone breakdown products, which are the products of those bone breaking down cells called osteoclasts, or the other one is a bone formation marker, which is a product of the bone forming cells called osteoblasts. Now, if we give either a treatment to increase bone formation or one to inhibit bone resorption or breakdown, they're the type of treatments we've got, we can then measure those things in a fasting blood specimen in the morning about 3 months after you start treatment and get an idea of whether the treatment's being effective. And I think it's very useful because if people are on tablets, we want to make sure that they're taking the tablets or taking them properly, and then we can get an early indication rather than waiting for 12 or 24 months and seeing that the bone density hasn't improved. We'll get an early indication that something needs to be done at about 3 months after they start treatment. And the same is true for these bone-forming drugs, which are more expensive. We want to make sure that they're being effective by seeing the bone formation markers improve at 3 months.
Okay, and are they useful for people who are not taking any medications, but rather making lifestyle changes? Would bone turnover markers be useful?
So I think they're probably not as useful there because we don't see great changes with the lifestyle approaches. So we probably only see minimal changes. And one thing, we could also use it with testosterone therapy to see if they were changing with testosterone therapy. If you're on that, that might be interesting, but it would take longer, maybe 6 months to have an effect. But yeah, I think what we tend to use them for is when people are put on treatments to get an early indication of the effectiveness of treatment.
And you mentioned earlier Romosozumab. I believe you were involved in some of the trials of that. Is that right?
Yeah, we've got a couple of, 3 anabolic drugs now in Australia. The first one was teriparatide, which was been around for about 20 years. And I was actually involved in the study in men for that many, many years ago. And then I was involved in the Romosozumab studies in women as well. So, and the other one is abaloparatide, which has just been approved for treatment in Australia. So that is actually based on a hormone, and I was on the team that discovered that hormone. So it all comes back to get you in the future. But so that's been interesting to see that development of that hormone into a treatment for osteoporosis.
Wonderful. So it sounds like you're very involved in different types of research. Is there any research that is being released or that you're working on now that's interesting that you can share?
Yeah, so I think what we're seeing is we've got these very effective treatments like the ones I mentioned, the anabolic drugs. There've been head-to-head studies with the existing anti-resorptive treatments, and it shows that they're more effective at reducing broken bones. The trouble is they're fairly restricted in how we can use them in Australia on the PBS, and the best way to use them is before you go on these other family of drugs, the anti-resorptive drugs. So you've got to use these bone-building drugs first. But you need to have quite severe osteoporosis to do that. So you've got to have an osteoporotic bone density and a T-score of minus 2.5 or less. So, but I think they're very good drugs to use and very effective.
Okay. And is there any hope of a cure or coming close to a cure for osteoporosis?
Well, I think we'd like to think that these new anabolic drugs, and there's another anabolic drug that's in development which acts like Romosozumab, but there's an additional inhibition of an inhibitor of bone formation, which is a bit complicated, but it looks like it's got a longer effect on increasing bone formation. I think we're getting to the stage, if we can prolong the bone forming effect of these drugs, where we can often increase the bone density quite quickly in 12 months. So in the patients I've had on Romosozumab, sometimes you can actually increase the bone density by 20% over 12 months. In the trials, it was about 14%. So we're heading in that direction, I think.
That was Professor Peter Ebeling, one of the leading experts in bone health worldwide, particularly men's bone health. And a huge thank you to him for sharing his time and wisdom with us. So for the men out there, osteoporosis is not just a women's condition. Up to 40% of osteoporotic fractures worldwide happen in men. So the sooner you act, the stronger your future will be. Pun intended. And so if you found this useful, hit the subscribe button and share it with a mate who you think might find benefit in it. And I'll see you in the next one.